Today's presentation will cover an overview and recommendations for building the CDI program at JW Ruby Memorial Hospital. This information is presented by Sherry Miller and Courtney Magic for HIIM 246, Fundamentals of CDI, instructed by Professor Simmons. First, we will start with an overview of JW Ruby Memorial Hospital. JW Ruby Memorial Hospital is an academic medical center located in Morgantown, West Virginia. The medical center has 751 beds and is accredited by JCAHO and has licenses to be a verified trauma program with a Level 1 trauma center and a Level 2 pediatric trauma center. Total yearly discharges are 32,350 with a number of discharge days of 193,087. JW Ruby Memorial is a nonprofit with total patient revenue of $4,507,223,622 annually. JW Ruby Memorial is an academic medical center, so yes, they do have interns and residents. Their high and low CMI areas are as follows. They have high CMIs in the cardiovascular surgery, neurosurgery, surgery, and vascular surgery departments, with lower CMIs in the psychiatry, cardiology, and orthopedics departments. JW Ruby Memorial provides a wide variety of clinical services, as you can see highlighted on this slide, from cardiovascular services all the way down to wound care. Next, we will cover the CDI mission and vision statement. The mission of the CDI program is to ensure accurate reporting of coded data, clarifying provider documentation that's ambiguous, conflicting, or represents an unintended meaning, and to align the organization's clinical and coding definitions. Our vision statement is to be recognized as a premier organization whose documentation reflects our quality of care. Next, let's talk about building and staffing the CDI program. Some questions to consider when building your team are as follows. What department will CDI reside in? The recommendation would be for CDI to reside in HIM. Who will the CDI reviewers report to? The recommendation here is they would report to the job title of a lead and then supervisor. Who will be the executive sponsor? It's recommended that the CMO is the executive sponsor of the CDI program. Who will be the physician advisor? The recommendation would be for the physician advisor to come from the hospitalist department. What departments will be on the CDI core team committee? The recommendations are coding, compliance, and quality outcomes. Next is how many CDI reviewers and why. The recommendation would be to have 21 CDI reviewers, per the 1 to every 1,500 discharges calculation. What will the CDI reviewer job title be? The CDI reviewers will be known as CDI specialists. This slide shows an example of the CDI job description. The position overview, the Clinical Documentation Improvement Specialist is responsible for competency in coordinating and performing day-to-day operations, providing concurrent and/or retrospective review, and improving documentation of all conditions, treatments, and care plans to ensure the highest quality of care is provided to the patient. The CDI specialist will also perform education for clinical staff in the appropriate documentation criteria. Qualifications for this position include an associate's or bachelor's degree in a healthcare-related field with an RHIA, RHIT, CCS credential, or an RN or MD license is required. Competencies for this job include identifying principal and secondary diagnoses in order to accurately reflect the patient's hospital course, utilizing ICD-10-CM with appropriate application of coding conventions and guidelines, ensuring accuracy of the MSDRG grouping and APC assignments, promoting CDI efforts throughout the organization, and collaborating with physician champions to promote initiatives, fostering a working relationship with CDI team members, querying providers in an ethical manner and tracking compliance, and developing CDI policies and procedures to include query process, education and training, and performance tracking. This slide shows the organizational chart for the CDI program at JW Ruby Memorial Hospital. The chain of command starts at the top with the CMO. The VP of HIM reports up to the CMO. The CDI director and physician advisor would both work closely with the VP of HIM and the CMO as well. Under the CDI director is the CDI manager. The CDI manager would have 2 CDI supervisors that report up to them. Under the supervisors, you would have 3 CDI leads, 3 CDI educators, and 21 CDI specialists who would report up through the leads and the supervisor.
The keystone of every CDI program is physician training in high-quality clinical documentation. Unfortunately, physicians do not receive this training during medical school or most residency programs. We propose the use of a scientifically validated method for clinical documentation training known as the CAMP method. This method draws upon the adult learning theory of self-efficacy and uses the components of coaching, asking, mastering, and peer learning to teach physicians the principles of high-quality clinical documentation. Coaching reinforces the ability to perform their functions of CDI. We'll do that by sharing experiences about clinical documentation. Asking is about getting feedback at specific milestones during the training. Talking about concerns at the beginning and follow-up throughout the training. Mastering is practical application of the skills you've learned in the training. Practice creating high-quality documentations with training courses. Peer learning is instruction by a knowledgeable peer, and this is where the feedback can be applied to improve the program. Moreover, the CAMP method is proven to produce significantly better documentation results than traditional training provided by most physicians' CDI training programs. If you recall from the earlier organization chart, the CDI education supervisor will be filled by the executive office, and the 3 training positions under this supervisor will require all the qualifications of the CDI specialist from before, with the added skills of training and clinical documentation of at least 80 hours, patient record documentation review, at least 5 years experience, providing classroom training, at least 40 hours of experience there, and providing practical feedback of at least 100 to 160 hours. All of these CDI educators will be provided training in the CAMP methodology, in the use of PowerPoint for developing training presentations, and resources and tools. Our intention is to train your trainers so that they can step in and sustain your program. A customized curriculum will be provided by us, which will become your property to revise after implementation is complete. The focus for your facility will be in the areas of your case mix index that are high. Those include cardiovascular surgery, neurosurgery, general surgery, and vascular surgery. By starting in these high CMI areas, we can see the results more quickly on the most important revenue areas, and we'll begin with these providers. Now, while we know the hospitalists and residents in these areas do have heavy schedules, we need to impact them minimally, but they need to be trained first. The organization can decide which members of these groups can be provided with training first based on who they recognize will see the benefits and support the program. Once we show the benefits, we'll win the naysayers over with evidence. Now, our recommendations include the initial camp training, which will be given in two 2-hour training sessions. We'll spend time focusing on answering the questions, what is CDI? Why is CDI important to providers? And what action does the provider need to take? Again, we recommend a 2-year rollout, with the second year focusing on make-up sessions for specialists, new staff, or anybody who may have had difficulty with scheduling initially. We suggest that each new class of first-year residents complete CDI training going forward. We know they don't get this training in medical school, and so the earlier we get this group to understand the concepts of CDI training, the better off everyone will be. Additionally, a benefit is that with the planning of this, the competency requirements of the Accreditation Council of Graduate Medical Education will be met. So there's an added bonus for that. The actual content will focus on the 7 criteria for high-quality clinical documentation, which is legibility, reliability, precision, completeness, consistency, clarity, and timeliness. This, on the other side, shows the example of the 2-year schedule based on provider type. And of course, all training will need to be updated with regulatory changes, staff changes, evolution of quality initiatives within the facility, expansion of the CDI to other areas, and any ongoing refinement of the program with the assistance of the medical staff that you deem required. The CDI specialist will be trained also in the 7 criteria, as well as the basics of coding and reimbursement in your facility, data collection, and analysis processes. This training includes query training. The types of queries we will want to work with will be multiple choice, yes, no, and open questions. The appropriate format will depend on the case in question. Our first example here is a case where there was not quite enough documentation about a fracture. So the coder queried the physician, providing some specifics that could be answered within the documentation, such as open or closed, the laterality, type of fracture, or if there was a cause that could be documented. Another example here is the term urosepsis. This does not have a code in ICD-10-CM, so some additional qualifiers will need to be provided by the physician so that the proper code can be assigned and documented correctly. And these are both examples of an appropriate query based on CDI principles. Some of the key measures of performance will include both concurrent and retrospective review rates, query rates, response rates, and validation or agreement rates. Your facility will determine your own target metrics as well as policies and procedures around those rates. By dividing the measurement by the target, you get the achievement rate. As this data is collected and reviewed, problems and trends can be identified, and this information can be used for CDI improvement efforts. As you can see from this data, the attention is required to those with the lowest achievement rates. These rates can be compared on a monthly basis to measure improvements or a need to adjust. However, with the measurements being made available on a daily basis through some CDI software products, it is also possible to view the changes through dashboards. These will be especially useful for hospital administrators and executive staff to get a quick look at all the stats. A sample dashboard may look something like this, providing a lot of data in a quick view, easy format. In addition to these dashboards, software programs can provide metric information by coder, provider, or service area. We do have some additional recommendations. We do recommend a CDI software program that will allow the ease of the query tracking and reporting statistics. Innovative technology is constantly emerging, and AI is becoming a part of the billing and coding process. This may eventually replace some of the lower level coding positions, but the CDI program will be in the unique position of being able to review these changes, and they will be important as these technologies evolve. Finally, our company is committed to keeping you up to date with best practices and will help you when you're ready to expand your program into other care areas. Thank you for your time today, and we appreciate your business.